Professor Rima. I think this is beautiful introduction, and thanks for Dr. Ala for giving me the opportunity to be with you today. Now, I'm going to talk about aortic stenosis beyond gradients. Now, since the days or drawings of Leonardo da Vinci in 1512, there have been tremendous achievements in the diagnosis and treatment of aortic stenosis. Now, aortic stenosis is very common and the most common valvular lesion in the Western Hemisphere, and it is mostly there due to sclerotic aortic or calcific aortic stenosis. In this part of the world, it is mostly due to rheumatic heart disease, in addition, of course, to sclerotic heart disease or aortic disease. Now, mortality increases with all grades of aortic stenosis, not only severe aortic stenosis as it used to be in the past, but it's also with all grades of aortic stenosis. This is a study which was published in January 20. I think this is not working, unfortunately. This is a study which was published in January this year, and it showed that there is very good correlation between the Vmax, or the velocity of the aortic valve, and the all-cause mortality. And this is one of the new things, not only in severe aortic stenosis. Now, with the advances in TAVI and wide experience with it, of course, we need many modalities to get to the diagnosis and accurate selection of patients with aortic stenosis going for the TAVI. Now, still up till now, transthoracic echocardiography is still the gold standard imaging modality for the assessment of aortic stenosis severity. This is December 2022. And when you get a case like this, with the peak gradient of 141, mean of 80, and area of 0.4, 0.5, this is a straightforward case that this is severe aortic stenosis. There is no problem with such cases. But of course, there are other cases where actually it can be more problematic. I have to stress a point here that to make a precise diagnosis of aortic sclerosis, when the gradient on the peak velocity is less than 2.5 meters per second. Beyond that, we talk about mild aortic stenosis or moderate aortic stenosis, and so on. Now, the aortic valve area, sometimes we may have to do it by planimetry, whether on transthoracic or on TEE, and that's slightly different from what we derive by the continuity equation. Continuity equation gives us the effective orifice area. This is the anatomical aortic area or geometric aortic area, and we all know how to calculate the aortic valve area by continuity equation. I think this is straightforward, and the machine does that automatically. Now, still, actually, the guidelines and the definition of severe aortic stenosis, when the aortic valve area is less than 1 square centimeter, and the mean gradient greater than 40 millimeter mercury, or jet velocity greater than 4 meter per second, or 64 millimeter mercury. Now, the same still reiterated in the latest European guidelines in 2021, so there is no change in such definition. Now, I think there was some people still actually underestimate the gradients by not picking up the right area to get the gradients from, and it has been shown now for almost 10 years that the right parasternal window is the most fruitful for getting the proper gradient. It's more efficient than the conventional apical view. Now, there is actually, we just heard about the handheld echocardiography, and this is in December 2022, that it has been shown actually to be useful because they now incorporated the continuous wave in it. And now this is what we obtained, or what they obtained from a conventional machine, and these are the velocities or jets, excuse me, obtained by the handheld echocardiography. So I think there is actually comparable view, and I think it is reasonable, a very reasonable correlation. Now, when we talk beyond the gradients, let's start looking at the anatomy of the valve, not only just looking at figures and gradients. So we have to look at the anatomy, and this is a classical example of a patient with rheumatic valvular stenosis, rheumatic aortic stenosis, and that's a case of a sclerotic or calcific aortic stenosis. And there are differences between the two. Now, with calcific aortic stenosis, we got nodular calcification on the leaflet. There is no commissural fusion. You can see the commissures here are completely open. To the contrary, with rheumatic aortic stenosis, we get commissural fusion, as you can see here, and this is actually a characteristic about rheumatic aortic stenosis. One important point when we are looking at the aortic valve is to try to avoid the calcification when you are measuring the aortic valve annulus. This is very important because that can affect, of course, the aortic valve area. There is in 2023 now, in JACE this month, there is actually a novel application of 2D calcium quantification method, and this is a software in the machine where it measures the mean pixel density of the entire valve in relation to the mean pixel density of the annulus here. And this is actually, it shows the ratio. When the higher the ratio, the worse the aortic stenosis. This is a mild aortic stenosis, moderate aortic stenosis, severe aortic stenosis, and they have been shown to have moderate to strong correlation with such calcification. Of course, CT scan plays very important role in the assessment of patients with aortic stenosis before selecting the patients for TAVI. But still, the effective orifice area is the method of choice because it has been shown to have better correlation with the clinical and functional variables than the geometric area. But this is actually in patients with bicuspid aortic stenosis here, and that's December 2022. Some people forget to add in their report the dimensionless index, and that's very important, particularly when you are dealing with a prosthetic aortic valve. And this is easily taken by just determining the TVI, or the peak velocity of the LVOT jet here, to the peak velocity of the aortic jet. And the ratio, if the ratio here is less than 0.25, that indicates a critical aortic stenosis. Now we move forward to other measures, other parameters, and this is in November 2022. The importance here is shown of getting the acceleration time. Sometimes we forget to measure the acceleration time, and this is quite helpful in differentiating patients having pseudo-aortic stenosis from true severe aortic stenosis in patients with low flow gradient aortic stenosis. And the best cutoff value of acceleration time is 100 milliseconds. When it is more than 100 milliseconds, that is more in favor of true severe aortic stenosis. And there have been a lot of work on the importance of acceleration time in patients with heart failure. reduced ejection fraction. Not only looking at the valve, look at the arteries, because we know that 30 to 80% of patients with calcific aortic stenosis have hypertension. So we have to look at atheromatous plaque in the aortic root, we have to do the carotid duplex, and so on. Now, looking at the valve beyond the ejection fraction, we heard elegant presentation from Dr. Ashraf this morning about the importance of strain. And this has been actually shown particularly. This is important before getting the patient into this case of severe impairment of LV function. It is easy to pick, but what's important is to pick the case before reaching such a stage. And we know that 1/3 of asymptomatic patients with aortic stenosis and normal ejection fraction have reduced longitudinal function, reduced GLS. So I think this is important to pick up before getting into advanced left heart failure. Now, this is a nice current, a novel echocardiographic assessment of the ejection fraction. Not only looking at the strain, what we have seen today, GLS here of 21 in mild aortic stenosis. This is a case of moderate aortic stenosis. And you see that it is reduced down to 16, and severe stenosis reduced down to 11%. There is actually, this is a novel model here, with software incorporating the blood pressure by non-invasive way in addition to the strain information. So why? Because the myocardial deformation or getting the strain imaging, it has still an afterload, is still afterload dependent. So to overcome this, people added actually or combined the use of myocardial deformation imaging with non-invasive blood pressure monitoring, and they got what's called a myocardial work, as it is here. So this actually is important because we need in aortic stenosis to think about the mechanisms of all the changes occurring in such condition. We know that aortic stenosis lead to left ventricle pressure overload, left ventricular concentric hypertrophy, diastolic dysfunction. The LA will respond to that and cause LA remodeling. And further on, we will get left ventricle and left atrial fibrosis. And this is the cause of the heart failure and arrhythmias patients end with in aortic stenosis. We heard elegant presentation from Dr. Ala about the left atrial strain in such cases, and this is an important message here that after SAVR or TAVR, when we assess the patients, we get actually very fruitful measurements quite early. The left ventricle volume and ejection fraction start to improve after 1 week, believe it or not. The left ventricle strain observation and improvement improve within 1 week. The left ventricle diastolic function improve, and the left atrial strain a little bit more delayed, up to 40 days before it showed its improvement. Now, one other important point is the staging of the severity of aortic stenosis. We look at aortic stenosis and we forget about the sequelae sometimes of aortic stenosis. And this actually model has been introduced in 2017 by Genero and Piparo, and they actually classified the stages of aortic stenosis into 4 stages. Stage 1, where actually you get LV damage, and there is increased LV mass, there is a reduced ejection fraction, and of course the GLS will come down. Stage 2 of aortic stenosis, when the patient starts getting left atrial and mitral valve damage, and that is shown by moderately severe mitral regurgitation, showing atrial fibrillation, and so on. And the patient progress and progress. Not only aortic stenosis is not limited to the aortic valve. It affects every single chamber and every single component in the heart. And the stage 3, where we start getting tricuspid damage, we get significant tricuspid regurgitation, pulmonary artery systolic pressure goes up, and the stage 4, when the patient gets dilatation and reduced function of the right ventricle. And this is actually quite advanced stage of aortic stenosis. Now, is this reliable staging? Yes, it has been shown recently in November 2022 in a study done on over 900 patients with TAVR. And they found that this classification was very fruitful, and there is good association between the cardiac damage and 1 year mortality. So that is a meaningful assessment. Now, what about myocardial infarction? Do patients with aortic stenosis get worse if they had a heart attack? And the answer is probably yes, because this is a study, not a large study, but it showed that in patients who had myocardial infarction, there was progression of their aortic stenosis, and that's assumed because of increased collagen production and thickening of the aortic valve. Now, what about the stress echocardiography? Do we need stress echocardiography when we are selecting patients with TAVR? The answer is probably not, because I think the role of stress echocardiography in TAVI is less defined, while in selecting patients for transcatheter edge-to-edge or mitral valve clip, yes, there has been shown that stress echocardiography is proved to be useful. Now, finally, what is the role of cardiac catheterization in assessing patients with aortic stenosis? I think there is very limited role nowadays. It is used to clarify inconsistencies, or when there are discordance between the findings or not actually conclusive findings from the echocardiography, CT scan, and so on. But we have to remember that the figures we are getting on cath are a little bit different from the figures we are getting in gradients. So finally, ladies and gentlemen, look beyond the gradients. So look at the valve, see the calcification ratio, look at the arteries, look at the ventricle with the strain, and look at the LA strain, and do staging classification to get full picture of what's happening in the state of aortic stenosis. Finally, I will end with this statement by Carbello that in aortic stenosis, no number trumps clinical judgment. With this, I will thank you very much indeed for your attendance.
Thank you very much, Dr. Hassan. Actually, as always, you're an eminent speaker. Thank you for this excellent presentation. And as we mentioned earlier, we will leave the questions to the end of the sessions. Personally, I do have one question, so we would like to welcome our second speaker, Dr. Akram Niaz Ahmed. Please come forward. Yeah, he's over here. So Dr. Akram is actually a consultant cardiology and echocardiography at Dr. Samir Abbas Hospital from Jeddah. Dr. Akram is board certified with the Saudi Board in Internal Medicine, Saudi Board in Adult Cardiology and Echocardiography, National Board of Echocardiography from the USA. So he will here give us his talk. So welcome, Dr. Akram. Tafadhal.
Assalamu alaikum. Thank you, everyone. Thanks for inviting me to this fruitful forum. Just waiting for this to connect. Okay, so Assalamu alaikum everyone again. My talk today is about the aortic stenosis evaluation after TAVI or TAVR, and I'm going to start with a case. So this was a 65-year-old female who had symptomatic, very severe aortic stenosis. Her peak velocity was almost 7 meters per second, mean gradient was more than 100, and the calculated valve area was 0.4 centimeters square. She was at high surgical risk due to comorbidities. And so based on the valve guidelines, in this patient with symptomatic severe aortic stenosis, she meets criteria for either SAVR or TAVR. Previously, the option of TAVI was mainly for patients at high or prohibitive surgical risk, but since the multiple partner trials, it's even been FDA approved in low surgical risk patients since 2019, and it's being done more and more. And now the 2020 guidelines actually recommend TAVI as a class 1 recommendation for all patients above the age of 65, okay? We know that there are two major types of prosthesis, the Edwards-Sapien valve and the Medtronic core valve. The Edwards valve, it needs to be deployed and placed by inflating a balloon after the valve has been correctly positioned. And it's got a small profile, it's cylindrical in shape. And that's what the valve looks like after it's deployed. The Medtronic valve, on the other hand, is a self-expanding valve. The mechanism for deployment, after it's deployed, you can appreciate that it's got a cylindrical or a smaller part in the LVOT, and it becomes bigger in the proximal ascending aorta. So when it comes to assessing the function of the valve after TAVR, we have to look at two major components. The first is the visual appearance, the positioning, and also to look at the hemodynamics of the valve. So in terms of position and location, we need to ensure that the valve is secure and stable in position with minimal impingement on the anterior mitral leaflet. We should also ensure that there's no coronary ostial obstruction. So this is a normal Edwards valve. The edge of the stent is usually 2 to 4 millimeters below the aortic annulus. And on the Medtronic valve, it's about 3 to 5 millimeters below the aortic annulus. When seen in the short axis, a good deployment is when the valve is circular. Sorry, the stent is, circular. But if it's ovoid, it's not fully expanded. That means that the valve has not been completely or fully deployed and placed correctly. Some common pitfalls that Dr. Hassan went over. In the native valve, we should always try to measure the LVOT diameter right at the annulus and not proximal to it. We should also try to exclude any ectopic calcification because that's going to give us a falsely small LVOT diameter and affect the measured orifice area. So in TAVR, where do we measure the LVOT diameter? It's not measured at the near the annulus. It's actually measured at the inferior edge of the TAVR stent. We take the measurement from the outer edge to the outer edge. And we should also try to position our pulse wave Doppler sample volume at the same level to get the valve area. Okay, so positioning of the LVOT pulse wave Doppler volume should also be done in such a way that we don't see any of these opening and closing clicks. We should move a little bit more proximal into the LVOT to get a complete signal without the opening and closing clicks. Also, when trying to get the tracing, we might need to decrease the gain to make sure that there's a good black-white interface that we can trace along it to get the VTI for the pulse wave for the LVOT. What about the continuous wave Doppler? The sample volume obviously should be adjusted so we don't see two envelopes. We should be seeing one dense, uniform spectral profile. And we shouldn't forget looking at the other views like the parasternal to get the actual maximum peak velocity. So the normal continuous wave Doppler signal in the prosthetic aortic valve kind of looks like the one in the native mild aortic stenosis. It's got a triangular shape, it's got an early peak, and as Dr. Hassan mentioned, the acceleration time, it's the time from the onset till the peak. So if there's any obstruction or stenosis, you're going to find that the peak is going to be farther ahead and the acceleration time is going to be increased. There's also a measure that we use sometimes, which is the ratio of the acceleration time to the whole ejection time. So if the acceleration time takes up a lot of the ejection time, that again points towards significant stenosis in such patients. Effective orifice area is obviously calculated by the continuity equation, and we all know it depends a lot on the LVOT, so any changes in the measurement or variation is going to affect the final calculated area. DVI, on the other hand, is something that doesn't really use the LVOT. It just measures the ratio of the flow at the LVOT to that of the peak velocity, and it's a simple parameter that we can calculate. Here on this table, you can find the normal values for the different kinds of valves, the Medtronic and the Edwards and the Medtronic. So even on the smallest valves, that's size 23, the effective orifice area is usually 1.1 centimeters square or bigger. Obviously, as the valve gets bigger, the area is going to be a lot bigger. So having gone through all the Doppler parameters that we need to get an idea about the hemodynamics, this is a simplified algorithm from 2009, actually. We have some updates later on. So if we have a peak velocity that's more than 3 meters per second, we look at the DVI. If the DVI is less than 0.3 and 0.25, and then we look at the acceleration time. If the acceleration time is more than 100 milliseconds, that probably suggests that this patient has significant stenosis. After TAVR, the complications can be divided into early or late. Early complications are usually like prosthesis, migration or embolization. TAVR thrombosis and valve degeneration is usually late. And patient prosthesis mismatch can be both early and late, actually. This is an example of a patient where immediately post-deployment, the valve was in the proper place, as you can see. But upon follow-up, the valve actually migrated into the LVOT, releasing the native valve. So this patient had significant stenosis. This is an example of an Edwards valve that went in the opposite direction. It embolized into the descending aorta. Now coming to TAVR thrombosis, it occurs in about 3% of cases, and it should be suspected when there is more than 50% increase in the gradient from baseline, if there is increased leaflet thickness and decrease in the cusp mobility. Here is an example. This patient has thickened valves. You can appreciate that the mobility is reduced, and in this case, it was because of premature discontinuation of the dual antiplatelet therapy because the patient developed GI bleed. What about patient prosthesis mismatch? The basic idea behind PPM is that the valve leaflets are opening and functioning well. The only issue is that the size of the opening is small when compared to the body surface area of the patient. So what we find here is usually that the indexed orifice area is going to be low, and almost all of the parameters are usually within normal. If it's less than 0.85, that means there's some patient prosthesis mismatch. And if it's severe, if it's less than 0.65 centimeters square per meter square. It's obviously not benign. The worse the degree of the patient prosthesis mismatch, the worse the outcome and mortality in these patients. So in actual stenosis, the area and the index area are both going to be low. The acceleration time is going to be prolonged. Whereas in the patient prosthesis mismatch, morphology is going to be normal. Everything is normal except the index orifice area. Now let's talk about pressure recovery. Pressure recovery is when we have in the LVOT, we have something called pressure energy. And as it goes through the vena contracta, it's converted into kinetic energy. So the potential or pressure energy that we have initially is decreased. It's really low at the vena contracta. And after it crosses the vena contracta and goes into the ascending aorta, some of the pressure energy is recovered, but not all of it. Okay? So when we're measuring the gradient by echo, we're going across the whole valve. It measures the gradient between the initial and the lowest here. Whereas when we're measuring by cath, we put the cath transducer in the ascending aorta and in the LVOT, it's going to give us the difference between the initial and the recovered. That's why we'll notice a lot of times that the pressure gradient on cath is much lower than on echo. This becomes more relevant in cases where we have smaller ascending aorta. So if we have a large ascending aorta, the pressure recovery is minimal. So the difference in pressure gradient between cath and echo is not going to be that much. But in those that have a small ascending aorta, there's quite a bit of pressure recovery. So that's why we end up having a difference in pressure gradient between cath and echo. Now it's a debate which one's more accurate, which one's more physiological. But I guess by echo, we're measuring just the difference between the LVOT and the convergence. But the cath actually measures what's going through after the valve. This discrepancy was also seen in patients post-TAVR, and the difference was statistically significant as well. So the guidelines include measurements of pressure recovery. They have these formulae we can use. And they also have something called energy loss index, which takes into account this pressure recovery and gives us an idea about the corrected valve area based on the ascending aorta area, which is the AAA. We shouldn't forget that the gradient may overestimate severity if the stenosis is contaminated by the MR signal, obviously, if the traced area is larger than the actual envelope, or if we have a high flow state as well. And the gradient may be overestimated if we have if we have failure to align the Doppler beam, if it's a low flow state, or the patient has high blood pressure. This table here is a summary of the causes of different causes for high gradient. So obstruction, we're going to have criteria that all go with stenosis. And there's also a change in the ratio of the area to the DVI when compared to baseline. There's going to be obviously abnormal cusp motion. We're going to have low DVI. And conversely, in the patients with high flow, just the gradient is going to be elevated. Everything else is going to be normal. In patient prosthesis mismatch, the gradient's high, the effective orifice area index is low, and everything else is going to be normal. Pressure recovery, we already went through the different parameters, and we're going to have no change in the cusp motion. We're not going to have a change from baseline in terms of ratio of area to DVI. Aortic stenosis is not an isolated valve issue. There's also vascular load or arterial compliance that we need to take into account. And there's also the global arterial load, or the ZVA, valvular arterial impedance. It's a simple thing we can calculate by just using the systolic blood pressure, the mean gradient, and the indexed stroke volume. So we have different values for all of these parameters to assess whether the aortic stenosis is significant or not. Going back to our case, the patient had very severe aortic stenosis, underwent TAVR using a 23 millimeter Medtronic Evolute R valve. The mean gradient after echo was around 15 millimeters of mercury. The echo as measured by, the gradient as measured by cath was around 10 millimeters of mercury. Upon outpatient follow-up, the patient was found to have a peak velocity of 4.4 meters per second. Mean gradient was 35.
You have 1 minute left.
Sure. Was 35. The valve area was 0.93, but the index valve area was 0.56. The DVI was 0.41. Acceleration time was 80 milliseconds. Patient had energy loss index of 0.83, which was not severe, not less than 0.65. The vascular load was also within normal. The global impedance was also not meeting criteria for severity. So looking at the reference values for the size here, the effective orifice area of 0.93 was within accepted range. The DVI was also within the accepted range, but the index area was quite low. So this patient probably had a patient prosthesis mismatch causing the high gradient. In summary, this is a simplified algorithm that we can follow to go through patients who have high gradient after TAVR, not to miss any of the diagnosis. And thank you very much.
Thank you, Dr. Akram. Interesting talk, especially, We're expecting more TAVI patients and more TAVI failure in the coming decade, so we need to have a solid indices for such patients. Thank you very much. Let me introduce our next speaker, Dr. Hani Mahmoud Al-Sayed. Dr. Hani is a consultant cardiologist and director of Echocardiography Lab at Aswan Heart Center, Sir Magdi Yaqub Foundation in Egypt. He's a committee member of the European Association of Cardiovascular Imaging and a committee member also of a lot of scientific committees and a lot of board certifications from the National Board of Echocardiography, United States, and also Dr. Hani served as a senior clinical fellow cardiovascular imaging in Queen Elizabeth Hospital, UK. Dr. Hani will talk to us about the 3D transesophageal echo in mitral paravalvular regurgitation. Please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for the introduction. So as it has been said, I will be speaking about the mitral paravalvular leak. What can the 3D echocardiography add? It happens usually due to dehiscence of the prosthetic valve, whether mechanical or biprosthetic, from the native mitral annulus. Although we know that it happens more frequently in the mitral position compared to the aortic and other valves, and it happens more frequently in the mechanical compared to the biprosthetic valves. Surgery has been always the treatment of choice in such patients. Previously, if we have patients with paravalvular leak, whether to leave them alone if they are high surgical risk, or to treat them surgically. But luckily, with the advancement of the interventions and the imaging modalities, I have to say imaging because I'm an imaging guy, we now, for selected patients, we can offer them percutaneous therapy. As an echocardiographer, we need to address the patient at many steps. First of all, to diagnose the patient, to detect the severity of the paravalvular leak, and to check if it is suitable to be closed percutaneously, and of course, inside the procedure in the cath lab and follow-up. We are speaking about 3D, so 3D has a lot of added values, as we will see later on in many things, especially in multiple leaks, in defining the shape and size, the localization, the guidance of the procedure, and so on. So speaking about the localization, I usually like to use the clockwise approach. Starting from the surgical view of the mitral valve that everybody saw today and yesterday, putting the aortic valve at 12 o'clock position, posterior mitral annulus at 6 o'clock position, septum will be at 3 o'clock, and the left atrial appendage will be somewhere at 9 o'clock. Having this in our mind, we need to speak to the surgeon, speak to the interventionist in the same language. So for example, even if you have a 2D TE probe, having the long axis view, which comes usually between 120 and 140, if you see a defect more or less close to the aortic valve, this is not like a sharp cut at 12 o'clock. With some tilting, we can go for like 11 or 1 o'clock, but this is more or less somewhere here. Do you agree with me? So if you see this, and you see a defect near the aortic valve, that means you can localize this somewhere near 12 o'clock position. On the other hand, a bit of angulation from the commissural view, if you see something near the left atrial appendage, we know that the left atrial appendage is around 9 o'clock. So roughly, you can say this is somewhere a lateral defect near 9 o'clock position. So what to do? This is a proposed protocol that I published 2 years ago. You have to start first with the 2D. Don't jump immediately to the 3D, and we will see why. 2D first, and then turn the color on. Why? To make sure this is not an artifact. Because if it is an artifact, color will not pass through. So 2D first, and then 2D with color on. Now I can see the color is passing through. This is a real defect, not an artifact. Okay, well and good. Now we will activate the narrow sector live 3D. Who have attended yesterday's workshop? Yeah, we have seen the narrow sector live 3D, not the 3D zoom, not the full volume. Why is that? Because narrow sector live 3D gives you the same frame you started with some elevation. So if you see a defect in the 2D, and then you see a defect in the 3D, this is a real defect, not an artifact. So don't let the defect go away from your sight. Stay, keep the defect in the screen, just narrow sector live 3D, the live 3D, then you will see the defect with some elevation, the thickness, the depth of the image. Now I know this is a defect. And then I enlarge the elevation width, which is like, falsely we can say anteroposterior, the depth of the image. We can increase the thickness. Again, I'm still seeing the defect, and then I orient the image to the surgical view. Now I didn't lose the defect. I have the aortic valve 12 o'clock position, so this defect is somewhere like 11 o'clock. Do you agree with me? So why is that? This is from down. And again, this is a straight track defect. What does it mean, straight track defect? It's like a window. If I'm staying in the left atrium and I'm looking from the defect, I can see the left ventricle, right? Because we will see other shapes of defects now with sliding track, and it has implications in the treatment. So that's a straight track defect. If you are looking like an ASD, if you are in the left atrium, you can see the left ventricle directly, whether from the LA or the LV. So this is the protocol that we published. 2D, color on, live 3D, increase the sector width, orient the image, and then you will have the clockwise orientation. Do not get deceived by 3D immediately. If I told you this patient, that's another patient, has a paravalvular leak, can you clockwise the defect? I think most of you will look at this, right? The same as me. But color on, the defect is there. This is just an artifact. Why is that? Because the prosthetic valve was a bit higher than the native annulus, but it is attached, it is intact, creating some shadow. So that's why you shouldn't jump immediately to the 3D. 2D first, make sure this is a real defect, then live 3D, and so on, as we said. Color is very helpful. This is some, or more or less, a surgical view, but the defect is there at 11 o'clock. That's why sometimes I need to turn the image down to see the defect. See, the color gives very good localization, especially if you have higher frame rate. Sizing and shape. Look at this huge defect. Huge, right? So the valve, I'm not sure why the valve is not working, although all this defect is there. But I cheated you for the next time, but this is the last time I will trick you. This is the exact same patient. Okay, what did I do here? The gain. Yeah, I decreased the gain down. Many of those patients have atrial fibrillation, stasis in the left atrium. So in 3D, you will see this brown signal inside the left atrium. We tend to decrease the gain to get rid of the brown signal, right? The more you reduce the gain, the more you lose the thin tissues of the annulus and the left atrium. And you create a very large defect, which is not true. So what to do? Just decrease the blood signal, this brown signal, a little bit till you can see the valve and stop there. Don't over reduce the gain. Otherwise, you will oversize the defect. And sizing shouldn't be done on the 3D image itself, because now with the new machines, we can freeze and we do tracing, right? We can do this, but this is not advised. In patients with paravalvular leak or mitral stenosis, sizing should be done in the MPR, like what we did yesterday in the vena contracta area. Do you remember what we did in the vena contracta? The same. We will put our lines in the middle of the defect, then we'll put the third line exactly at the tips, then we'll have a short axis or an on-fast view, and we measure it. Why is that? Two reasons. We said one of them. If we measured on the 3D rendered image, it is liable for gain artifacts, like what we did. Number two is the projection. What does it mean? If you see this paper, Dr. Abdul Halim Kinsara sees this paper with a certain dimensions because he's just right in front of it. He sees the height and the width. From this side, I'm sure you will see the height the same as Dr. Abdul Halim, but the width is less because he is facing that. So if I tilted this paper, although it is the same dimensions, the projection of this paper in your eyes will change the dimensions. Now the vertical dimension have become less, right? And now the transverse dimension has become less. That's why in the 3D rendered image, you are not sure that you are really making the valve flat in front of you. But in the MPR, you don't have this problem because you are putting all the lines exactly at the tips and you don't care about the tilting, because at the end of the day, you will measure on a straight image, an on-fast image. So please, image or size on the MPR. That's why some people, sometimes, those who are a little bit obese, they tend to take pictures like this, right? Because they look thinner, not like that. No offense. Okay? The same we can do with the 3D with color, like what we did in the vena contracta area, to measure the area of the defect. And we have the opportunity to grade the severity of mitral paravalvular leak using these numbers, 0.13 and 0.65 as a length, and you have with and without color. These are different shapes of defects. I'm not cheating you anymore, believe me. Here, this defect is from 6, like to 7 or 7:30, we can say. That's again straight defect. If we are in the left atrium, we can see the left ventricle. But look at this defect. I can't see the real defect. The valve is supraannular a little bit, but there is something here, but I can't see a straight path. It is not like an ASD. It is not, I can't see the left ventricle from the left atrium. That's why I need to get this by the narrow sector live 3D. See that? It is bigger than the annulus, actually, and dehisced. So the defect is from like taking a sliding track from the left atrium to the left ventricle. This is very dangerous in terms of percutaneous closure. If you see this, think twice before sending the patient to the cath lab, because the previous one, the straight one, if they insert the catheter from the LA through transeptal puncture or from the LV, it will go straight away to the other side without touching the discs of the valve. But this one, if they try to insert a catheter from here, it will take this sliding track and touch what? The discs, and it will impair the motion. I don't care about the defect, even if I close the defect fully, but the valve is not working, so what? What's the benefit? We tried first, when at our beginning of experience, to close this defect, and we never won. Usually we get caught in the discs and then deploy or try to get away from the discs with smaller plugs, and then we have residual leak. So my advice, don't try in these kind of defects. This is a side view for the same defect, see? Up and down, this is not a straight track defect. So the guiding the closure have many steps: transeptal puncture, wire catheter positioning, and assessment of the result, and so on. Of course, this has to come through a heart team discussion. Heart team discussion is very important. The imaging guy is the wise guy in the middle. Interventionist C is looking to the imaging, asking him to say suitable for percutaneous closure. Surgery is always sad because he's losing cases, no more jobs, and anesthesia doesn't care. He's going to sedate the patient anyway. Yeah. Transeptal puncture, we have seen that a lot. The rattle maneuver to get the surgically oriented view of the interatrial septum from the right side. You can see a catheter coming from the IVC towards the SVC, and this is the fossa. You can see the catheter coming down to impinge or tent the septum. You can guide this very easily using the rattle 90 maneuver, and we have published this. If he is coming from the apex, transapical approach, you will not be able to help him seeing the catheter inside the LV, because if it is a mechanical prosthesis, everything will be hidden by the shadow of the mechanical prosthesis. But you will help him telling him whether his catheter is coming through the valve itself or from the defect, because it can happen. Sometimes they insert the catheter comes through the valve itself. And before they notice this in the hemodynamics and in the fluoroscopy, you can tell them, no, take it back and bring it from the defect. Wire and catheter positioning. This is through transeptal approach coming from the IVC, puncturing the septum all the way to the defect. This is another view, starting from something like a bicaval view, superior vena cava, inferior vena cava.
1 minute.
Okay, I'm almost there. See? Now the discs are moving, and the cannula or the sheath is there. This is the complication I'm telling you about. See, passing through the defect itself. Take it back, put it in the right place. This is through transapical approach. You can see only the plug being pulled back to the catheter. Yeah, just less than half a minute. هي مع البيبل السلايد بتقف. Yeah, freeze. خلاص. So this is the final result for this particular patient. Assessment of the result, two main things. Actually, I should put this one in the beginning. So prosthetic malfunction and leaflet mobility. This is the most important thing. Safety is first. And then after that, is there any residual leak or not? 3D can help a lot. Just one view, see the defects opening and closing very well. Because 2D, you know, 2D, some cuts will give you a sense or like a false impression that one disc is not moving. But 3D, you will see both discs are moving. By color, you can assess if there is any residual leak or not. And for further reading, we published this 2 years ago, added value of three-dimensional TEE in management of paravalvular leaks. So in conclusion, TEE isn't mandatory in paravalvular leaks, but 3D has a lot of added values in terms of localization, shape and size detection, and guidance of the procedure. Thank you so much. Yes?
A beautiful presentation as usual by Dr. Hani. Now our next speaker is one of our dear colleagues, Dr. Zakaria Ibn Musa. He is one of our junior colleagues in the Saudi Heart Association with a lot of activities and a lot of really promising future. Dr. Zakaria is the head of Echocardiography Division at Prince Sultan Cardiac Center in Riyadh. He's an adult cardiologist, echographer, and interventional as well. Dr. Zakaria, please proceed.
Thank you, Dr. Arima, and thank you for the organizing committee for bringing me back to my hometown. And also thank you for Al Musa Hospital for this nice meeting. This is my disclosure, and I will start with the history, some history though. So the edge-to-edge repair started in maybe in 1990, early 1990s, with Professor Alvieri, who's an Italian surgeon, started his surgical technique to repair the severe MR with the stitch between the anterior and posterior leaflet. It looks simple, but unfortunately it didn't do well as an outcome. So it didn't persist in the field of surgery. Then it took almost 20 years for a company to have an idea and to use it as a percutaneous intervention, and they published in 2011, sorry. In 2011, they published their data for Everest 2 trial showing feasibility and safety of percutaneous edge-to-edge repair. It works, and it has it grow the popularity. And then in 2018, in COAP trial, it showed both mortality benefit and hospitalization also benefits. So nowadays we are seeing the mitral edge-to-edge repair gaining more popular. They are really increased demand all over the world and also in our country. Before to go for the this technique, you have to make sure to choose the correct patient. These patients should be optimally medically treated with coronary vascularization at the beginning, and if they need resynchronization therapy, should be done first. You have to make sure that they have severe MR and they are symptomatic with recurrent hospitalization on top of all the medical treatment we mentioned. Additionally, they are having high or prohibitive surgical risk, denying them from surgical repair. The ideal case usually for mitral tear or, edge-to-edge repair, although these are rarely we are seeing, but I would say they should have the single jet between A2 and P2, no commissural jet, thin mobile leaflets, no leaflet calcification, no MAC, not rheumatic, with posterior mitral valve length of more than 10 millimeter, the mitral valve area more than 4, gradient is low or no gradient. Make sure that there is no very large gap for primary MR. No severe LV dilatation with adequate septal height. The proposed protocol for screening of these patients to choose these good, to have an ideal, or let's say for your selection for the procedure, it includes both transthoracic echo and transesophageal echo, including you have to assess, the mechanism of the MR, the severity, the LV assessment, and the look for any prohibitive condition which we mentioned later on. The transesophageal is the golden, let's say, investigation or the imaging technique for those patients where you have detailed assessment of the mechanism of the MR, the mitral valve apparatus, look for unfavorable features. You assess the interarterial septum and the LA appendage, and then you have to make sure, you have to decide about your choice of the device, which device you're gonna choose. So starting with the mechanism from the transthoracic echo, you can easily look for, let's see. Yeah, so you can easily identify the primary MR where you see any prolapse or a flail leaflet, or look for the secondary features where there is a tethered posterior mitral leaflet with a relative prolapse of the anterior mitral leaflet associated with LV dysfunction or regionality in the posterior inferior wall. Look, exercise your knowledge and the whole guideline, let's say, that you know for assessment of the MR severity, including the mitral valve morphology, qualitative measures or qualitative assessment of the mitral valve regurgitation, and then the quantitative assessment, including the vena contracta, the BISA, and also other parameters. So you have to make sure that you are dealing with severe mitral regurgitation. For LV assessment, you go for the dimension. Make sure that you have a good assessment of the dimension, although I like to go for the volume, because simply the volume will give you an idea what you are dealing with. So we know that we said about COAPT trial, which showed a positive result, but there is another trial, which is the MITRA France, it showed a negative result. So the only explanation for that the selection of the patient for the MITRA France, the LV dilatation was, the MR was proportionate for the LV dilatation. And those patients, if you do for them the edge-to-edge repair, they have less benefit. Well, on the other hand, the COAPT and the Everest were selected earlier in their journey of the disease, where they have disproportionate MR. What does that mean? It means that the degree of the MR is disproportionate to the degree of LV dilatation, and those patients, they benefit the most from the procedure. So you have to maybe catch your patient early in the disease, not to leave them till they lose the benefit of the procedure. Now, going to the transesophageal echo, so it has the major rule to identify the mechanism accurately, whether it is a primary or secondary. Again, assessment of where is the MR segment, the mitral valve segment that involved in the etiology of the MR. So you decide where is it to decide your strategy for the intervention. Like here, it's a primary where it is more of a lateral flail segment of A2 toward A1 maybe. On the other hand, when it is secondary, you will see that the posterior leaflet is restricted and there is a relative prolapse of A2 segment of the mitral valve. Importantly, also to look for if there is any gap, and the location of the MR as well, whether it is, as I said, middle, medial, or lateral. In the primary mitral valve disease, you look for a flail gap, and you measure it and the flail width, which should be done in the bicommissural view. The assessment of the posterior mitral valve leaflet length should be done in the 120 or 130 degree, where you have to measure the mobile part of the posterior leaflet, and to avoid the chordae, not to measure it, so it will give you a longer measurement. Importantly, to assess how many segment, as we said, how many jet of MR, whether it is a single MR, jet of MR, where is it? Is it located centrally or medially? Because this will affect the choice of the device and the number of your strategy for the number of devices you're gonna use during the procedure. As we said, and we also, you might go, you have to assess whether how wide is the jet, whether it is narrow or wide, because this will affect your strategy for choosing of the device, as we said. 3D has important role to identify the location and as well how wide is the jet as well. Important part of your assessment to go for the pulmonary vein flow reversal, which is observed during the procedure, before and after, because this is a hemodynamic result of your procedure, whether there is an improvement in the pulmonary flow before and after the procedure. Sometimes I use the LVOT VTI to look for the stroke volume before and after. However, there is a bit of controversial because we know that the stroke volume and the LVOT VTI is not only affected by the mitral valve regurgitation, it's affected by the LV dysfunction and the ejection fraction. So sometimes we do use it, but we are carefully interpreting that during our procedure. The mitral valve apparatus is an important part of your assessment because you want to know the distribution of the chordae, how is deep, and if there is any calcification in the chordae. Simply because when you have a jet that it's in between these chordaes, you want to make sure that you avoid entrapment of the device during your procedure. Part of your assessment as well is to assess the mitral valve area, which I agree with Dr. Hani for the assessment. I don't usually assess the mitral valve area on the 3D, but directly. You have to use the MPR for assessment. This is very accurate assessment of the mitral valve area, and look for the gradient, which should be less than 5. Optimally, it should be less than 1 or 2. The intra-arterial septum is part of your assessment. You have to look for the thin septum. Try to avoid the PFO during the transseptal puncture, and you look for the thin and any interfering with the devices or the ICD as well. The intra-arterial septum height, it should be done in the 0 degree, and you should take it from the coaptation line or from the annulus to the thin part of the septum. Make sure that you get more than 4.5. We do sometimes less than 4, but it will be difficult for the interventionist, so they have to know to do some maneuvers to gain height during the procedure. Now, unfavorable features for that you might not go for mitral valve clipping or edge-to-edge repair is the mitral valve annular calcification, significant, severe calcification that protrude into the LV cavity. Rheumatic mitral valve you should avoid because simply you can see there is a fusion of one of the commissures, and the area will be low and the gradient will be high, so these are not suitable for mitral valve clipping. Assessment of the mitral valve area, as we said, it's important. And finally, the short posterior mitral valve leaflet, less than 6-7 millimeter is really difficult especially for early experience. The lowest we have done is 7, and really it was difficult to grasp during the procedure. just one more slide. So the choice of the device, so it depends on the posterior mitral valve leaflet length. For smaller, shorter posterior mitral valve leaflet, we use the NT, whether NT or NTW. For larger one, or I mean more longer posterior mitral valve leaflet, we go for XT. Now we have 4 devices: NT, NTW, XT, and XTW. For the W, it is wider, so this is should be selected for wider jet. The other device we are having is Pascal device. It's a larger device. It has a spacer within. It's claimed to be nicer and I mean more delicate on the leaflet. It has also good result. There are 2 sizes of the Pascal, B10 and B6, and still we are having the early experience with that device. So in summary, the echo protocol for mitral valve tear screening, it should include transthoracic echo and transesophageal echo with full details of the mitral valve anatomy, mitral valve regurgitation assessment, full assessment, and suitability for the device. Look for the prohibitive conditions and the interarterial septum, and the choice of the device you should decide it after full assessment. Thank you.
Thanks, Dr. Zakaria, for this excellent presentation. We are coming across the end of this session, so I would like to call the speakers forward. We will have like 5 minutes to get some questions. Less than 5 minutes? Okay. So I have actually 2 questions if somebody doesn't have. Huh? So I have 2 questions. Question to Dr. Hassan about aortic stenosis. You mentioned about the longitudinal strain affection, which is an early stage in the aortic stenosis. Would there be like a cutoff value where you can predict or send patients earlier before they drop the ejection fraction? Because still till now the guidelines are all talking about ejection fraction as a number. And I have a second question to Dr. Hani about 3D echo and optimization of the 3D. So do you have like a specific range for optimization when you have a 3D zoom to eliminate all the dropouts and the artifacts you see in terms of the gain, compression, smoothing, and also thickness? If you have like numbers or ranges, you can give us also will be nice. So Dr. Hassan.
Thank you very much indeed. Excellent question. Answer in the guidelines, it is not. There is no to give actual for surgery. But I think, having said that, I think some people, some authorities say 16% is probably an indicative of early procedure or early intervention. In the guidelines, still actually it's not well defined.
Very practical question. Actually, there is no single number that can work for every single patient. As I said, some patients have a lot of stages, atrial fibrillation, very large left atrium, and some of those you will have to decrease the gain compared to other patients. But as like a simple answer, start by an average 2D image. So play all of your like tricks on the 2D image first, and then it should be fine. For this particular patient, if you see a lot of stasis, the patient left atrium above the valve before on the 2D, decrease again till you get an average image on the 2D, and then start acquiring the 3D. For the sizing, that's an important point. I usually, when I do a patient, I take 2 sets of images. Some images to show the interventionist or the surgeon. This is, I have to reduce again to show them the valve, okay? But on average, reduction to avoid artifacts. And some other images overgained. Even you can't see anything in them. And when I display this in front of them, I tell them this is only for sizing, ignore it. So I put the overgained images in the MPR. Okay? So I take two sets of images, one to show people, and the other ones are to do the offline analysis using the MPR, because if you overgain an image, still in the MPR, you will see a difference, a contrast between the blood pool and the tissue, and you will completely avoid any dropout artifact. Is that clear? So the images on which you will do the offline analysis, overgain them. Okay, acquire them overgained, even if you can't see anything in them, just like brown lump. Because in the MPR, you will still be able to see the difference between the blood and the tissue. And that, by this, you avoid any artifacts. But you have to take some images to show the surgeon or to show the interventionist that in that images you should reduce again a little bit to show the structure. I hope that answered the question.
Thank you, Dr. Can we take one more question?
I have, okay, please, yes.
Any question?
We have plenty of questions now.
Thank you. Thank you. Excellent presentation, all of you. One question for paravalvular leak in the setting of infective endocarditis. I have a young female. She had mitral valve replacement for rheumatic baseline. And after 5 years from the surgery, she came with severe paravalvular leak, closed percutaneously by Dr. Rida. After 5 years, she came with pseudoaneurysm, large pseudoaneurysm. Most likely the underlying pathology is endocarditis. Dr. Hani. My questions, paravalvular leak in the setting of endocarditis. What is the best treatment? Another question for Dr. Hassan. One question allowed?
That's a more of a clinical question rather than, but I think this is a common clinical scenario. That's why we shouldn't intervene with any patient during an active infection, unless we do surgery. I mean, percutaneous approach in patients that is just recovered from infection or on active infection is contraindicated because you don't know how far the things will go. This thing was actually, it might be an extension of the pre-existing infection, and this is the normal process, thinning out and then pseudoaneurysm. You successfully closed the defect, but things were like getting worse and thinning out, and with the hemodynamics pressure overload, these thin parts became an aneurysm. That's why we shouldn't intervene with patients unless they are very well settled, very well established, get them out of infection. If they are not in active heart failure, give them some medications, like let them settle. Everything will be fibrosed, and then operate on them, whether percutaneously or surgically. Yeah.
The golden rule that, I'm a pediatrician basically, but the golden rule is that we've learned and we're still learning, don't send patients with active endocarditis to OR. And a good surgeon will not accept those cases. So this is one of the sequelae that something was done without complete treatment of the pathology. Maybe it was something in the tissue, an abscess, whatever is there, we don't know. 6 weeks, okay. And all her parameters were negative, ESR, CRP, whatever. Okay.
But so that when the reason of the paravalvular leak or the problem is the endocarditis, it tends to reoccur, and unfortunately there is maybe hidden organism that will flare up later on, even with adequate antibiotic. So it is a dilemma how to treat this patient, because most of them, even if after surgery, they will develop another paravalvular leak. So I don't think we have an optimal plan for these patients.
Just one quick comment. Look for other hidden causes of endocarditis. Q fever, brucellosis. I've seen several cases. The cultures, all cultures are negative, and yet the patient has got a brucella endocarditis. So I think you have also to look for other causes of hidden endocarditis. Thank you.
negative والvalve كان
But just, معلش, this is an important teaching point from Dr. Basha. This is important for all of us. Where do you get the best gradient for aortic stenosis? In the parasternal long axis? Because, I mean, this will, all the suprasternal, where you can get, and another thing to Dr. Akram, because you were saying that avoid the two peaks, while Dr. saying with the two peaks you get a different index in the aortic valve.
Thank you very much. I think the conventional method, usually we look from the apex, but it has been shown that taking the picture and the gradient from the right parasternal, upper parasternal, is very, very fruitful, and you get the highest figure of the gradient.
So not the long parasternal, the right parasternal.
Right parasternal, right upper parasternal.
Thank you, Dr. For the two envelopes, for the DVI, you could use it, but if you want the mean gradient or the peak velocity, it's always best to take the densest signal without having two envelopes in it.
Also, we talk about mean aortic stenosis. That will go and correlate with the CAT numbers, right?
Most of the time,
As cardiologists, please correct me, we don't go by peak percent and for balloon or for surgery. We always get the mean.
both peak, mean, and
Decide whether to send for cath or surgery. I have a baby who's about, she's about 10 months.
Right.
Congenital aortic stenosis, and her gradient is 60, her mean is 30. So I will not refer her for balloon
Yeah.
until we get a
Sure.
protocol.
totally agree.